Well, I'd like to speak today a bit about the use of dynamic parameters in perioperative fluid management. Before I start, I'd like to thank Dr. Tom Higgins, who is the human in this picture, who helped me put this presentation together with some of his slides. The goals of today's lecture are first to talk about the history of perioperative fluid management. I'd like to make the case for a more aggressive perioperative management in terms of goal-directed therapy. I'd like to discuss dynamic parameters and how they can be used to meet that end, and then present an interesting case to you of a patient who was rather sick, who I think benefited in our institution from the use of dynamic parameters as we managed him. To my mind, there are four basic approaches to perioperative fluid management. The first, which was very common in the 1800s in particular, was the don't worry about it approach. The second, this is one where we make a lot of assumptions and then we give a lot of fluid. We use the 4-2-1 rule for maintenance, meaning 4 cc's per kilo per hour for the first 10 kilos of body weight, 2 cc's per kilo per hour for the second 10, and then 1 cc per kilo per hour for every kilo after that. On top of that, we give the 4-6-8 rule, which is for third space losses and insensible losses. That would be 4, 6, or 8, or sometimes even 10 cc's per kilo per hour of fluid for major operations. And then the final, we would give a 3-to-1 crystalloid replacement for any blood loss. So you can imagine for a major surgery, you could have as much as 1 or even 1.5 liters of crystalloid being given per hour for a Whipple operation, for example. The third is the making assumptions approach, but restricting fluid, say maybe only 4 cc's per kilo per hour total for the operation. The fourth, which is what I'd like to speak about most today, which is the goal-directed therapy approach, where we use hemodynamic parameters and oxygen delivery indices to decide exactly how much fluid to give. First, I'd like to speak a little bit about the don't worry about it approach. This is based on the firmly established fact that a single nephron is smarter than the smartest anesthesiologist, that we can simply give whatever amount of fluid we want to give to a young, healthy patient. Their kidneys will know what to do with it. Their body will know what to do with it. We don't have to worry about it at all. They'll take care of it. This was based on first limitations in the types of monitoring that could be used. The don't worry about it approach was used very commonly in the 1800s when there really was no other way to go. There wasn't known. Even blood pressure and heart rate monitoring might not have been so common during one of these operations. Well, this approach started to fall by the wayside in the early part of the 1900s when it was thought by some surgeons in particular that salt is bad for patients. This group of investigators, Dr. Moyer being the senior author, noticed back in 1944 when they wrote this up that many of their patients who received a lot of salt perioperatively had to spend more time in the hospital and had more complications than the others. What many of us think now, in retrospect, is that what he was looking at was that his sicker patients and the patients who had more complex operations actually needed the salt and then got that salt. So, but the basic rule that came out of this was that if you must give fluid, give dextrose in water and don't be giving saline. And this type of thinking lasted all the way through the century. Even as late as the late 1990s, I was working with surgeons at my own institution who would come in the room and say, I'm doing a big operation today on the liver. Please don't give any salt to my patient. Just give D10W to the patient. Well, in the 1950s, it started to be noticed that surgical patients seemed to require salt and fluid in order to stay stable. And this was probably because of what they referred to as the third space loss. Tom Shires is famous for this work in the 1960s in particular. And this is one article that appeared in the Annals of Surgery, acute change in extracellular fluids associated with major surgical procedures. And the data that they used to come to these conclusions were radionuclide data, noticing that the extracellular fluid compartment by radioactive tracer measurements was shrinking during major operations and needed to be replenished by salt solutions. So Jenkins came up with some suggestions on how we can keep up with this fluid based on the amount of fluid that was apparently being lost to the third space on the work of Shires. And this is where our making assumptions and giving a lot of fluid, namely crystalloid, by the 4-6-8 rule came from. And this teaching is still very common in anesthesiology texts. The Massachusetts General Handbook, which is our most commonly used handbook for anesthesiology, the Barish 5th edition, the Miller 5th edition, Miller and Stolting, what we affectionately call Baby Miller in our institution. These all have the 4-6-8 rule or 8-6-10 rule for the use of fluid. And just to prove to you that I'm not lying about this, this is a scan from Stolting and Miller, 5th edition from 2007, showing you that up to 10 cc's per kilo, up to 4 cc's per kilo in 10 kilo patients. In 11 to 20 kilos, you would give 2 and then 1 ml per kilo after that. You can also see underneath that you have the redistributive and evaporative surgical fluid losses, and then guidelines for intraoperative maintenance and replacement with crystalloid therapy, even with that 3-to-1 crystalloid for blood replacement rule down there near the bottom. So this is what our anesthesiology residents are reading, and this is what they're taught. Well, in the 1990s, it started to be suspected that maybe giving a lot of fluid in this way, particularly crystalloid, might be bad for a patient, that patients can swell quite a bit. Some of my senior colleagues will tell me, don't worry about the crystalloid, don't worry about how much you're giving, it's merely cosmetic. That they look a little swollen, they will be swollen for a couple of days, they'll mobilize the fluid, they'll get rid of it, and they'll be just fine. You just have to give them what they need. Well, I suspect that it's not merely cosmetic, that you can actually get into some problems by giving someone a lot of crystalloid in order to constantly be trying to replenish this third space loss with crystalloid. It can lead to heart failure, increase in lung water, bowel anastomosis problems, airway issues, a swollen airway. Any of you who have done a prone spine case where there's been a lot of blood loss and you've given a lot of fluid, if you've given lots and lots of crystalloid, you turn the patient over at the end of the case, you see this big swollen airway. Well, if you lose that airway, if that endotracheal tube comes out, the problem becomes a bit more than merely cosmetic. There can be skin breakdown. There may even be vision problems. You know, these optic nerve problems that might occur with spinal operations. Perhaps that's a compartment syndrome, and perhaps large amounts of fluid are part of the problem there. Also, giving a lot of fluid, frankly, you end up with problems in your relationships with the surgeons. The surgeons are the ones who have to deal with all of this fluid and the mobilization of it and the extra time the patient has to spend in the hospital for this. If you can figure out another way where you don't have to give quite as much fluid but have a very nice, stable patient, then I think your relationships with your surgeons will benefit. So in the 1990s, it was thought, as I said, that perhaps restricting fluids would be the way to go. And there are two fairly thoughtful articles, I think, about this. One by Brandstrup, The Effects of Intravenous Fluid Restriction in Postoperative Complications, a comparison of 2 perioperative fluid regimens. And then one you see at the bottom of the slide, Effective Intraoperative Fluid Management on Outcome After Intra-Abdominal Surgery. This was by Nisanovich. And both of these articles encouraged the use of fluid restriction. There's an important caveat about fluid restriction when I mention it, and that is they're not talking about giving the person no fluid or absolutely as little fluid as possible. They're talking about giving, I think, a sane amount of fluid, say 4 cc's per kilo for the whole operation, and then replacing blood as you have to, perhaps considering the use of colloid and not just a crystalloid when you're taking care of these patients. So when we say fluid restriction and someone comes to you with this article and says, if you're an anesthesiologist and says, please restrict fluid, they're not talking about running the person absolutely dry and placing the patient at risk, but rather cutting down on that large amount of fluid that might be dictated by those rules I was telling you about in our texts. So to my mind, we've got some inescapable conclusions. Too much fluid, water in particular, is bad for patients. You have edema and all of those problems that I mentioned before with heart problems, lung water, airway edema, and so forth. Also, I think we can all agree that not enough fluid is bad. You can have inadequate tissue perfusion. The kidneys can be put at risk. The other vital organs can be put at risk. often our assumptions about the invasiveness of the surgery are invalid, and our assumptions about what a patient can handle are invalid. So I think that fluid management should be more individualized than perhaps it has been in our practices. That brings us to the subject of goal-directed therapy, using more patient data and fewer assumptions as we manage our patients. Well, goal-directed therapy, what data is it that I'm talking about? We all measure heart rate, blood pressure, urine output, things like that, oximetry, end-tidal CO2. What I'm talking about are also measuring stroke volume, cardiac output, some dynamic parameters, which I'll speak in detail about, the use of stroke volume variation or pulse pressure variation as an index of volume, central venous oxygenation, whether it be superior vena cava oxygenation or mixed venous oxygenation as can be obtained from the Swan-Ganz catheter, tissue blood flow, there are now new technologies out there about that, and tissue oxygenation. There's near-infrared spectroscopy that is now hitting the market that you can use to make some assessments about tissue oxygenation. Well, where does this kind of thinking come from? It comes from a landmark article by Manny Rivers from 2001. This was published in the New England Journal of Medicine, Early Goal-Directed Therapy in the Treatment of Severe Sepsis and Septic Shock. The hypothesis was that immediate aggressive treatment of septic patients during the golden hours, meaning the first 6 hours in an emergency room, is going to lead to improved outcome. This is something that Dr. Rivers noticed in his practice over the 1980s and then finally decided to do a study to prove it to the rest of us so that we can have our surviving sepsis campaigns be successful now. So he looked at 263 patients with sepsis treated in the emergency room. They were randomized and blinded in their ICU course. The ICU docs were blinded to what happened in the emergency room to these patients. And there were two groups, the so-called goal-directed therapy group, which used venous oxygenation as a cardiac output surrogate, and the standard therapy group. One of the strong things about the article, first to say, is that the standard therapy group patients were getting good basic care in the emergency room. They were not being ignored. In the goal-directed therapy group, Dr. Rivers elected to follow superior vena cava saturation and to keep that greater than 70% in his patients, keep the hematocrit greater than 30, the mean arterial pressure greater than 65, CVP 8 to 12, and the urine output greater than 0.5 mLs per kilo per hour. In the standard therapy group, they got essentially all of those things except for following the venous saturation and keeping it greater than 70%. They didn't actually have hematocrit greater than 30 as one of the goals, but the practitioners were free to give blood as they thought necessary in order to have the patient be safe and treated properly. So the big news was that the treatment group had a lower mortality. The in-hospital mortality was 50% versus 38% in the treatment group. Even the 28-day and the 60-day mortalities were improved. This was the first time anyone had shown any improvement in mortality data for sepsis patients since the introduction of antibiotics. This was huge news, and it spread everywhere. The conclusions: early goal-directed therapy, aggressive intervention in septic patients improves outcome and decreases utilization of resources. Well, this was not lost on anesthesiologists. This is one of a number of articles about intraoperative goal-directed therapy and how we can improve outcome. This was by T.J. Gann and his colleagues at Duke University, entitled Goal-Directed Intraoperative Fluid Administration Reduces Length of Hospital Stay After Major Surgery. And what Dr. Gann did, he took 100 surgical patients where the anticipated blood loss was greater than 500 cc's, gave 50 standard therapy, and 50 of them got goal-directed therapy. He used plasma volume expansion with hetastarch, and he used the esophageal Doppler device for stroke volume and corrected flow time data. His measurements were morbidity, mortality, length of stay, bowel function, renal function, nausea, and vomiting. Well, as I say, in the goal-directed therapy group, he used corrected flow time, which is an index of preload, and he used stroke volume to maximize using hetastarch and lactated ringers. In the control group, fluid administration was guided by our usual parameters: the urine output, the heart rate, and the blood pressure. First, as far as the results go, this slide indicates that they actually achieved the hemodynamic goals they were trying to achieve, where at the end of surgery, the stroke volume and cardiac output were higher in the protocol group than in the control group. Severe postoperative nausea and vomiting was less in the goal-directed therapy group, 14% versus 36%, with a statistically significant value, P. And length of stay was less in the goal-directed therapy group, 5 days versus 7 days. You may not think, particularly if you're an anesthesiologist, that 5 days versus 7 days or a 2-day change in length of stay is that big a deal. But if you're in a very busy hospital with a very busy OR, that 2 days can make a huge difference. You can paralyze the operating room and not be able to get patients through it if you're jamming up the post-op units with patients. So to my mind, that is a big difference, particularly in busy practices. It's also very big for the patients. The patients want to get home. They want to be with their families. You and I might not think a couple of days in the hospital is a big deal. The patient, I think, often will think it's a very big deal. So the conclusions of this article: length of stay appears to be related to the return of GI function. Hypovolemia is associated with post-op GI function, which is poor, with gut hypoperfusion. Early volume goal-directed therapy improves outcome in terms of length of stay and nausea and vomiting. Well, as I say, Dr. Gann was not the only person to do a study to show this. There are many studies now in the literature that you can go to, particularly by Rupert Pierce and Susan Sinclair, showing the same thing, that if it's major surgery, if you use early goal-directed therapy with well-designed algorithms to monitor the patients, that you can get an improvement in outcome and a shorter length of stay in the hospital. It all appears to be about optimizing tissue oxygen intra-op, and the timing appears to be critical, just as in the Manny Rivers study. That if you can get the fluid management in earlier, it doesn't necessarily mean you have to give more fluid. You just have to give appropriate amounts earlier. The timing is critical, as I say, with a shorter length of stay, and you get a better post-operative recovery. This results in a cost benefit, happier patients, happier surgeons, and frankly, happier administrators who have to oversee the finances for the hospital. Dynamic parameters I would like to discuss. Ventilation results in systolic pressure variation, and this was studied in quite a bit of detail by Dr. Perel, who is still doing some great work in this area. Pulse pressure variation, which was studied in detail by Drs. Pinsky and Dr. Michaud. For those anesthesiologists out there, there's an excellent review article in Anesthesiology from about 2 years ago by Dr. Michaud on this subject and how pulse pressure variation can be used for hemodynamic optimization. And then there's stroke volume variation, which we'll speak about a little bit also. The newer technologies now can provide stroke volume variation. Well, these dynamic parameters that happen, if we would like to understand the physiology of this, we need to back up a little bit and talk about the Frank-Starling mechanism and how the heart actually beats harder when it's stretched a little bit more. You'll notice from this slide that a muscle being stretched causes a better overlap of the actin and myosin filaments of the muscle fibers, and that actually results in a stronger contraction. So you'll see down at the lower right that as we add weight to this muscle fiber, it contracts harder. Obviously, if you add enough weight, ultimately it will fail, and you'll end up in the downward right portion of the curve. But in general, as we stretch muscle, the muscle contracts more efficiently and harder. So the Frank-Starling curve can be applied, of course, to the heart. And as you see, as the left ventricle is filled on the x-axis, the left ventricular output increases on the y-axis. And then when you get up to the flat portion of the curve, you notice that filling doesn't improve the contractility anymore. Essentially, the heart is maxed out on this. That's a normally contractile heart. Well, at the crux of this is that not all Frank-Starling curves are equal. It can differ between patients, and it can differ from one circumstance to the next. So as you see, as I showed you before, you've got the normal contractility curve, and then at the bottom you can see a failing heart, where as you fill it up, it might improve a little bit at first, but it will fail early as you fill it up. So the failing heart, you don't want to find yourself giving too much fluid. You can soon find yourself precipitating heart failure. So If you have a patient who has a low stroke volume, this can be interpreted in two possible ways. The first is that the patient is empty, that they are at the lower left-hand corner of this curve, and simply filling them up will cause an improvement in left ventricular performance. Or it could be a failing heart where you might be at the top of the curve, giving more fluid will actually harm them. The secret to managing somebody successfully is to know where they are on their Starling curve. So the magnitude of pulse pressure variation with respiration and stroke volume variation actually depends on the Starling curve. As I will describe a little bit later, that as we ventilate somebody with mechanical ventilation, we're actually giving them little fluid challenges, and then we're taking fluid away a little bit. This results in a fluctuation in the amount of filling of the heart, and the heart responds according to where it is on its own Starling curve. So positive pressure ventilation does result in a variation in arterial pressure. We're all familiar with that. We see it on monitors all the time, and we were all taught in our training to watch for that, that when we see a wide variation in arterial pressure with ventilation, that indicates that the person might be hypovolemic and would probably benefit from some fluid administration. That brings us to the subject of stroke volume variation, where, as I say, some of the newer technologies that are available can measure this for you. It's not just pressure now. These machines can actually tell you variation in stroke volume itself, which is what's causing this variation in pressure. So we're getting at the root of what's causing the variation. This is just one of many articles that have appeared in the literature about predicting fluid responsiveness in patients. These are cardiac surgical patients, but this has been done in ICUs and elsewhere to determine fluid status. The concept of pulse pressure variation and stroke volume variation dates back to Kussmaul and his pulsus paradoxus. Kussmaul was the investigator and the physician who first described this. In normal individuals, the systolic blood pressure drops 5 to 10 millimeters of mercury upon spontaneous inspiration. Filling impediments to either ventricle may exaggerate this with a drop in greater than 10 millimeters of mercury upon inspiration. The reason for the drop in pressure is that when you take a breath in, your chest wall goes out, intrathoracic pressure drops, so your pulmonary veins dilate, your pulmonary capillaries dilate, and they don't fill the left ventricle, the left atrium and left ventricle, as much as they would have. Then when you breathe out, the pressure goes up, that squeezes the pulmonary capillaries, squeezes the pulmonary veins, and then causes blood to go back into the heart. So this inspiration causes a drop in preload to the left side of the heart, and then when you breathe out, that's reversed. Well, pulsus paradoxus is caused by filling impediments to either ventricle. Causes can be hypovolemia, constrictive pericarditis, which is what Kussmaul was describing when he saw this, cardiac tamponade, and an asthmatic attack. These are just examples. Stroke volume variation, as we'll discuss it today, is actually the inverse of this. When a person is on positive pressure ventilation, and I'll discuss the physiology of that. Stroke volume variation and pulse pressure variation are proportional to one another. Stroke volume and pressure, pulse pressure in the arterial tree lock hand in hand. So the mechanism of stroke volume variation, as I understand it, is that a positive pressure breath results in an increase in intrathoracic pressure. This increase in intrathoracic pressure causes an acute increase in left ventricular preload. What happens there is the pulmonary capillaries are being squeezed, the pulmonary veins are being squeezed, blood is pushed into the left atrium, and then left ventricle. Then there's a Starling mechanism, the left ventricle contracts better, and then we have an acute increase in stroke volume. However, at the same time, you just emptied the pulmonary venous system. Also, the right side of the heart is not very happy about what you just did. Positive pressure in the chest causes an increase in right ventricular afterload by squeezing on the pulmonary arterioles and even the pulmonary arteries. And it also causes a decrease in right ventricular filling. You remember that you were taught in school that positive pressure inside the chest causes a decrease in venous return. What we're talking about there is venous return to the right side of the heart, that your peripheral veins pool with blood, blood doesn't come back into the chest, so right-sided filling decreases. This further results in an empty pulmonary venous system and then a few beats later, you notice that on your arterial line tracing that you have a delayed decrease in stroke volume. So this is the physiology of this. This happens normally in all your patients who are on positive pressure ventilation. But if there's a problem with filling, like constrictive pericarditis, as I said, or abdominal compartment syndrome, or pneumothorax, these sorts of things, and hypovolemia, which is very important, you can have an exacerbation of this phenomenon. So one key slide here to remember, and I recommend you're doing your own searches to convince yourselves of this if you're not convinced already. In a population, stroke volume variation predicts fluid responsiveness more effectively than pulmonary capillary wedge pressure, CVP, cardiac output, intrathoracic blood volume measurement, urine output, serum lactate, pH, base deficit, and cardiac end diastolic volume. Even on TEE, looking at the size of the heart in one cycle is not as effective as stroke volume variation in predicting whether that particular patient is going to bump their cardiac output in response to a fluid bolus. So, as I said before, this all comes down to the Starling curve, the stroke volume variation and positive pressure ventilation, because as I said before, each one of these positive pressure breaths is a little bit of a fluid challenge to the left side of the heart, and then fluid is taken away when you're not breathing for the patient. So if the person is responding to these mini fluid boluses, then certainly they're going to respond to that 500 cc's of albumin you'd like to give them. So, as I say, there are a number of articles about this. This is an article about the effect of volume expansion and pulse pressure. It was found that the more pulse pressure variation a patient had, then the more they would respond in terms of cardiac output when they got a fluid bolus. This is an article by Dr. Michard. Does pulse pressure variation predict preload responsiveness? Hemodynamic measurements were performed in duplicate in 40 septic hypotensive patients. They were looking at pulse pressure variation, systolic pressure variation, wedge pressure, right atrial pressure, and cardiac output prior to volume expansion, and then 30 minutes after volume expansion. And these were paralyzed, mechanically ventilated patients. What they found, first of all, was that there was a direct correlation between changes in cardiac index and the baseline pulse pressure variation. But even more importantly than that, they created what was called the receiver operating curve to determine how predictive this was. Just a few words about the receiver operating curve. On the left axis, you have the true positive proportion, and then on the x-axis, you have the false positive proportion. If you have a line going right up the middle, a straight line like this one with an area under the ROC curve of 0.5, that's like a coin flip. That's a test that doesn't tell you much of anything one way or the other. It doesn't lie to you, but it doesn't tell you what's going on either. As the curve moves up higher and more toward the left, you have a superior test. The more area under the receiver operator curve, then the better your test is. So then, as we get to the highest curve on the left, you've got an excellent test. A receiver operator curve greater than 0.9 area is excellent. So these are the receiver operator curves that Dr. Michard obtained in his study. And you'll notice that in a population, if you just take an isolated wedge pressure or an isolated CVP, right atrial pressure, it's not any better than a coin flip. The reason for that is that we all know that a CVP of 0 in a person who's not putting out urine, that means something. That means the person is probably behind in fluid, or you've got some kind of filling problem and you can fill. We also know that a CVP of 30 in someone who looks like they're in heart failure and is developing fluffiness on their chest x-ray and bulging neck veins, that means something also, that you're probably head on fluid. But in an isolated population, if somebody just comes up to you and says, the CVP is 8, it actually doesn't mean very much. 8, 6, 4, 12, 10 doesn't tell you very much. However, if you look at pulse pressure variation, or even systolic pressure variation, you notice you get a very good result because, again, as I said before, with the positive pressure ventilation, you're doing little Starling fluid challenges to find out where the patient is on their own Starling curve. And it's for that reason that over and over again, multiple articles have been published that show this exact same thing, that pulse pressure variation and stroke volume variation are going to be more effective than right atrial pressure or wedge pressure. So, as I say, pressure is not volume, and it is only the dynamic parameters that can tell you where the patient is on their own Starling curve. So stroke volume variation and pulse pressure variation seem to be pretty interesting, but is it merely academic? I come from a teaching institution. Maybe this is a good opportunity to teach the residents about some physiology, but are people really going to be using this? It seems a little bit complex. Well, at last count, I found 11 different technologies that are already available that are using either pulse pressure variation, plethysmographic variation, or stroke volume variation to assist people managing patients in their volume status. So I can tell you that this is not going away, that people are going to be using this more and more. I suspect that we'll see an explosion of this. This will be a standard parameter we use during major operations. Well, lastly, I'd like to present to you a case that we had at UCSD where we found that the dynamic parameter stroke volume variation was particularly useful and telling in a patient who was becoming unstable. We had a 78-year-old man for endovascular abdominal aortic aneurysm repair. He had a past medical history of hypertension, atherosclerotic heart disease. We decided to give him general anesthesia with positive pressure ventilation. We put an arterial line, and we used arterial pressure-based cardiac output technology to measure his stroke volume and to measure his stroke volume variation. We also put in a couple of large bore IVs. The surgeons cut down to the femoral artery after the patient was anesthetized as procedure for their stent placement. And then after they did this, the surgical resident got to help do this, and then they draped over the femoral region with towels so that it wouldn't distract them and that they would also keep it clean and sterile. And then they had the surgical resident who did this kind of stand over by the feet of the patient, and the two attending vascular surgeons went ahead and started working on this fairly complex stent placement. So we gave 1 liter of crystalloid over the first hour. The blood pressure was 136/78. The heart rate was 64. Cardiac output seemed to be pretty good for this 78-year-old. The cardiac output was 4.5. Stroke volume variation only 7%. As you follow stroke volume variation, as a general rule, maybe 12, 13% might be a cutoff for you, where if it gets to be much more than 13%, it's time to start thinking that the person might benefit from volume. So we thought that we were pretty much on the mark with volume, with a stroke volume variation of only 7%. His hematocrit was 38, and his oximeter saturation was 99%. So a nice, stable space shuttle mission. So just to show you a little picture of what they were doing, they cannulated the femoral artery down there on the left, and then they fed their devices up into the abdominal aorta where the aneurysm was that they were going to be stenting. So about 1 hour into the surgery, though, we noticed that the cardiac output had dropped from its baseline of 4.5 down to 3.1 liters per minute. The stroke volume variation had gone up to 35% from its baseline at 7%. Blood pressure was a little lower, 110/60, but looked okay. Heart rate was a little higher, 76, but okay. So what we thought, because of the change in stroke volume variation, that we were dealing with a volume issue, that there was volume loss somewhere. We got a little bit nervous about that because we knew there were things up in the great vessels. There were catheters and all sorts of devices up in the abdominal aorta. So perhaps there was trauma to the aorta or other great vessels or some other source of volume loss. So we mentioned this to the surgeons. We said, gee, looks like we lost some volume here, but everything's okay. They did a dye study of the abdominal aorta, and they said, no, there's no leak. It looks just fine. We think maybe you're giving too much anesthesia, and perhaps you should turn the anesthetic down. Well, at the same time, the surgical resident noticed that his feet were getting wet, and it was sort of a warm wet. And he looked down and he noticed that his scrubs were turning red and that there was bleeding from the cannulation site. So what we ended up doing was having to give 3 units of red cells, 500 cc's of albumin, and 500 cc's of crystalloid, and we managed to get the cardiac output to return to baseline at 4.5 liters per minute. The stroke volume variation returned back down to less than 10%. The heart rate came back down to the 60s, and for some reason the surgeons were very nice to us for the rest of the day. We learned a couple of valuable lessons from this. First of all, the APCO technology, where we could know either the pulse pressure variation or the stroke volume variation, facilitated the rapid diagnosis of hypovolemia with cardiovascular compromise. The heart rate and the blood pressure, the changes in those, they weren't that impressive. If somebody turned over to us and said, you know, maybe you're giving too much anesthesia, well, isoflurane can actually cause the heart rate to go up a little bit and the blood pressure to go down. We might have said, yeah, you might be right, I'll turn this down, rather than knowing right away that there was a problem with cardiovascular filling. The other thing, even more important, I think, is that we were able to titrate the treatment. We had an elderly 78-year-old hypertensive patient on the table where we were tempted to give lots and lots of fluid and resuscitation when we found out that all this blood was lost. But we were able to follow the stroke volume variation. We were able to follow the stroke volume and titrate the therapy to just what he needed for his Starling curve and his well-being. Well, so I've presented a case to you. I've presented the case for goal-directed therapy, and I've also presented some dynamic parameters to you for your consideration. And I thank you very much for your attention.